Good morning, everybody. We'd like to welcome you to our webinar on whole system collaboration, and today we'll have a particular focus on a crisis. Just to go through general housekeeping, please can we ask everybody to mute yourselves and turn your videos off until you're asking a question or entering into discussion. Then obviously please put your video on. It'd be nice to see you. If you have any questions, either feel free to raise your hand or also please use the chat function throughout the webinar this morning. And just to remind everybody that we are recording the webinar in order that people that aren't able to attend today can watch at a later stage. So without further ado, can I have the next slide, please? So first of all, let me do some introductions. So I'm Liz Cullen. I'm Head of Clinical Programme for Maternity and Perinatal Mental Health for Hampshire and Thames Valley, working across the South East during this COVID period. Myself and Jenny Walsh, who you'll meet in a minute, as Perinatal Mental Health Clinical Leads. Can I ask everybody to put themselves on mute, please? A bit of background noise. Lovely. Bit of music to entertain us for the morning. Run these webinars and I have been doing so since last March, and then obviously since January we started widening that out from just the South East to invite national colleagues to come and join us as well. So welcome to any national colleagues that are joining us for the first time today. So we will start off this morning with a quick national update from myself and Jenny. Then Jenny's going to talk through some work that we've been doing on whole system working and an infographic that we've developed. Then we will pass over to Sarah Fellows, who's a colleague of ours in the regional team, adult mental health team, who will be talking about all age crisis and urgent mental health care pathways. We've then got a short film with a series that we're introducing going forward. Hello, my name is. And this month it's Rachel, a perinatal mental health rapid response nurse. And what we're going to do is focus on some of the more unusual roles or slightly different roles to share with everybody. So there'll be a short film on that. And then lastly, but certainly not least, we're lucky enough this morning to have Detective Inspector Amy Shock, who's going to talk about child abuse investigations. So we had one of her colleagues spoke at the end of last year, and we've been doing a series looking at safeguarding, etc. So today is child abuse investigations. So another packed agenda. So without further ado, I will move on to the national update. Thank you. Next slide again, please. So these are slides kindly provided by the national team. So thank you very much to them for that. If there are any clinical network managers on nationally or national clinical leads, you may well have seen some of these slides before, but for the vast majority of our attendees, they won't, so that's why we are using them. So really just to start off by doing a big thank you for all the work that's been done in terms of to date in 2020, 2021. So although at the beginning of the pandemic, referrals actually dropped dramatically as a result of COVID, what happened between the period of May and November was that services saw far more women than they had seen in the previous period for the previous year. And despite the pandemic and all the issues with that, there has been continued recruitment and improvement in both service capacity and capability for perinatal mental health, and also the development and preparation of the work for the maternal mental health services and work towards the other LTP flexible ambitions. And that's no mean feat, and I think we feel both nationally and regionally that that's a huge achievement within extremely difficult circumstances. We've had to change the way of working in terms of virtual, the limitations in the ability to do face-to-face has also been overcome. There's been staff redeployment and sickness, but despite that, there has been really good progress in perinatal mental health. So well done to everybody. Next slide, please. So this slide shows where we're at in terms of meeting the access ambition. So the blue line is the actual access ambition. Is the access ambition. The orangey amber line is the actual figures as we have them. And then the grey is the trajectory, the estimated trajectory. So we had exceeded ambition in 2017-18 and 18-19. Within the financial year 2019-20, services nearly met the ambition. It was just short. And although progress has been maintained, and you can see that there is an upward trajectory, we will fall short and we will not manage the increase as planned for 2021. And within our own patch for South East, you will know that we're doing a series of both workshops, webinars, deep dives, etc., to look at the access ambition and our data and ensure that the data is flowing appropriately, etc. So it is a large piece of work that obviously we are continuing to work towards. Next slide, please. In terms of working towards recovery, Claire Murdoch, as national lead, sent out a letter back in January in terms of the planning and the priorities for Q4, and it's really clear, obviously, that mental health remains a top priority within the COVID pandemic, and that specifically for perinatal mental health, it's about meeting the increase in demand and capacity. Obviously, through that, the access target and also the flexible ambitions in terms of maternal mental health services, dads and partners, psychological therapies, and the expansions of pathways from 0 to 2 years. So they are still expected to be met and need to be met in full by 2023-24. There's been a very clear diktat that services should continue to expand and recruitment of staff should remain as a priority, and that in order to be able to do that, there needs to be full investment from the baseline funding for perinatal mental health. And locally, we've been working to look at that to ensure that services have received their baseline funding. And then also there's a massive bit of work going on in terms of promoting equality and addressing health inequalities, which are so key in the recovery planning and unfortunately have only been heightened by the COVID pandemic. And within our own work here in the South East, we're doing a big piece of work. Obviously, health inequalities remains one of our key themes in these series of webinars, and there's some more work that we're doing with Health Watch at the moment, and we'll be telling you more about that at future webinars. Next slide, please. So with the maternal mental health services, that has remained a priority, and we have been developing them within the South East. What I wanted to make really clear is, although, and we've mentioned this at many of these webinars, although the national comms remains embargoed due to the pandemic, locally that has been lifted, and that was lifted prior to Christmas. So you know, you are able to share comms locally in terms of your success as early implementers or fast followers, and obviously consequently make sure that you continue with that work and recruit. So the second implementation event for the early implementers and fast follower sites is coming up shortly on the 24th of March, and consequently we've moved our monthly webinar to the following week, the 31st of March, and the dates will come up at the end of the webinar for you, and invites have been appropriately changed as well. And then more recently there have been virtual support visits for the early implementers within February and March. So for ourselves, we had the Kent visit, which was actually the first national visit a couple of weeks ago, and we will have the Hampshire and Isle of Wight visit in a couple of weeks' time in March. There's a dedicated section within the NHS, the future NHS platform for maternal mental health services, and we would advise you to go and have a look at that. There's some great documents and resources there. And then also nationally, they're looking at how do we resolve issues and support implementation of the flow of data onto the mental health service data set. Next slide, please. So this is the logo for Thrive, which is the Kent Maternal Mental Health Services early implementer. And I just wanted to say a really big thank you to them for all the hard work that they've done to date on the development of their maternal mental health services. And also, you know, they were commended by the national team when the national team came in and visited them virtually in terms of their development. So really to say a really great well done to them for all their hard work. Next slide, please. I just wanted to finish this part by mentioning the Ockenden review. So the Ockenden review in light of maternity was published on the 10th of December with 7 immediate actions for maternity services across England. And the recommendations, they do refer obviously to perinatal mental health, particularly with regards to managing complex pregnancies and needing that to be integrated into the maternal medicine networks. So there's lots of work going on regionally and nationally in the development of the maternal medicine networks, and it's really important that we make sure that perinatal mental health is integrated into that, and certainly within the Southeast we are working to do that. And the development of the maternal mental health services will feed really nicely into that. They're both a bit of a mouthful, aren't they? So trusts, the maternity services within trusts have been asked to complete assurance assessment tools. They were submitted on the 15th of February, and at a regional level, we are just going through the process of assuring those assessment tools currently. So there will be further work obviously going on with this, and it's, you know, really important that we bring maternity and perinatal mental health together. Okay. So next slide, please. So just in terms of some resources, I wanted to do a plug for Tommy's have done a new partnership to support mothers with serious mental health and mental illness. That's in collaboration with NHS England, Public Health England, King's College London, and there's some great resources. The link is at the bottom. There's various resources both for professionals, also women themselves. There's Twitter feeds, etc. And it's really thinking about supporting women who may get pregnant whilst managing a serious mental health illness, but also about making informed decisions about when to get pregnant and how to treat their condition during pregnancy. And one of the things I wanted to mention is that there is an Instagram live session today at 1 o'clock for this. So if anybody's interested and maybe manages to have a lunch break, you might want to join. Okay, next slide, please. Next slide, please. We've got a, oh, lovely, thank you. And then also to mention, there are 3 new best practice guides that have been published. One of them is the Tommy's, so that's the second one. There's a lot of detail on here, purely so that you have this when the slide set comes out. So I won't go through it all, but the other guides are involving and supporting partners and significant others in specialist perinatal mental health services. The Tommy's one, as I've mentioned, and then a good practice guide to support implementation of trauma-informed care in the perinatal period. And there are various workshops that are being held over the next couple of months. Those dates and links are there. if you do need to register for those workshops, so the email address for the national team is included so that you can get yourselves registered to attend. Okay, next slide please, and I think I'm going to hand over to Jenny.
Yeah, thanks Liz. So morning everyone. Before I start, I just want to say a massive thank you to you all for keeping going. I hope that the announcement from Boris Johnson about the roadmap and the way out of the pandemic was some comfort to you. But I must say, I feel quite humbled because we did some deep dives with services yesterday, and just to hear just how hard you're all working out there, and the complexity of the women that you're seeing, and the caseloads that the numbers seem to be going up and up. So just a massive thank you to you all, and if you can tell your teams that from us as well, I think, you know, we'd really appreciate that, because we don't want that work to go unnoticed. So back to the infographic. For those of you that have been with us from the start, you'll know that a while back we shared an infographic and we got some feedback from you all. So today is to show you how we used your feedback to slightly change it. So if I can have the next slide, please. Basically, this is a tool for you all to use if you think it would be helpful. And one of the things that we had feedback about was that that space in the middle, so the image where currently those hands are showing, so that to try and represent family. So what we've actually done, and I won't move on just yet, I'll just talk through this slide. So there's 3 versions of this, and I'll show you all 3 of them. And it's really a tool that you may or may not find useful. It's totally up to you whether you want to use it or not. But we felt it was a good visual representation of kind of how services are changing a bit. And if you look in that semicircle, rather than having hard lines between services, it's much more blurred. And I think with the asks of the long-term plan, we just need to have some quite grown-up conversations about where these women are best looked after and who is part of that. So the bottom slides, the boxes, you can change those so that you're able to write into those. So if you wanted to use this when you're meeting with stakeholders about, say, maternal mental health services, or how you're going to increase your access target, or any of the aspects of the long-term plan, really, just to inform those discussions, and then you can capture some of your thinking in the boxes below. So if we can just have the next one, please. That's just another version of that middle bit. And then the third and final one. And if you don't like either of those, there's space to put your own image there. But on all of these slides, you've got the opportunity to change the text in the bottom boxes. So that's just a little tool, as I say, that may or may not be helpful. Hopefully it will be. If you're anything like me, I'm quite visual, so it's helpful to me to be able to sort of see it in this format. So I hope that's something that, you know, chimes with other people. Okay, so I think that's the last of that about the infographic. Obviously that will be coming out in the slide pack, and then you can use it as you wish. And then there we go. So as you know, today we're focusing on crisis, and it's so important to include the offer of adult mental health, and to make sure that people are aware of what's on offer, because these services are changing and there's been a lot of investment. So I'm really delighted to introduce Sarah Fellows, who is going to talk to us today about all age crisis and urgent mental health care pathways. And hopefully this will be a really useful update, because I think you'll be surprised at the amount of changes in this area. So over to Sarah. Thank you very much, Sarah.
Thank you ever such a lot, Liz, for asking me to come along today. And I really hope you don't mind, but I'm going to keep my camera off because I've got really poor internet connection. I keep getting a message saying that I haven't got good connection. I'm sorry. So I hope that you can all hear me okay. So yeah, thanks for asking me to come along today and talk about crisis. And I guess what I wanted to do is just start by flagging, and I'm very mindful that everybody will be, you know, well aware of the priorities in terms of the NHS plan, in terms of developing all age mental health crisis services. But I just thought I'd start off by just reminding us some of the priorities. So for 2021, there were some priorities which were highlighted in the update that we all had in from the national programme in Q1. And just to remind us that the NHS plan is asking us to provide capacity for an additional 70,000 children under 18 accessing NHS funded children, and 73,000 young people and children aged 0 to 25 and accessing NHS funded services. For 35% of coverage of 24/7 crisis provision for CYP, which combines crisis assessment, brief response and intensive home treatment. And the ask specifically by Q1 was that we reviewed CYP crisis response. We considered extending operation hours where we went 24/7 by combining with adult crisis services, and expanding additional crisis support in terms of crisis cafes, crisis houses, peer support, and through the voluntary and community sector and local authorities if available or applicable. And that was by Q1 for 2021. And that by Q3-4, maintain 24/7 all age open access, crisis phone lines, and continued development of 24/7 crisis services, and planning for the development of 24/7 intensive home treatment services when not yet in place, and ensure services can meet specific needs of children and young people where models are all age or combined with adult services. So the next slide, Liz, is an update more on the adult priorities. So for liaison mental health, 100% of SDP coverage of liaison mental health teams covering the needs of all ages, and 50% of liaison mental health teams achieving what we call the core 24 standard. And for adult community crisis care, 100% of coverage of 24/7 adult crisis resolution home treatment teams operating in line with best practice. Establish 24/7 open access urgent and emergency mental health services as a priority for Q1 in 2021. All areas to continue to improve the operation 24/7 open access crisis lines, including capacity of telephony systems, ensuring that they're free phone and follow-up care and crisis pathway. Continue investing in crisis and home treatment capacity and alternatives to A&E admission. Establishing local and thoroughly mapped directory of services, a DOS, to include all mental health, local authority and third sector services, and integration with local NHS 111 services. And I think I thought that you might be particularly interested to hear about that in terms of joining up with perinatal mental health and making sure that all of your perinatal mental health services are reflected fully and accurately in local DOSes. And services commissioners continue to work with children, young people, mental health from within adult services across the NHS and voluntary community sector to improve transition and consider the LTP ambition to provide a seamless offer to young adults, very important obviously, and then ongoing proactive monitoring and updating of the information available on the NHS UK Crisis Lines Service Finder, for example, regarding postcode search accuracy. So next slide, Liz, if that's okay. And then some of the flexible ambitions which services are working towards achieving by the end of 23-24 are to invest in crisis alternatives, such as safe havens and helplines, and peer support and drop-in support. to improve mental health response provided by the ambulance service, to access NHS 111, to have access to urgent mental health care via NHS 1, and to introduce access and waiting times for urgent and emergency mental health following a clinical review of standards, to eliminate out-of-area placements for adult acute care, which is obviously and continuing in a very big ask, and another flexible ambition by 23-24 to improve therapeutic support provided in adult mental health inpatient care. So next slide, Liz, if that's okay. So obviously linking in with this, or very aligned to this, is the targeted investment regarding and the activity regarding suicide prevention plans. So 40% of STPs providing suicide bereavement support services, finalise suicide prevention transformation funding in terms of wave 1, 2, 3 for 2021, and to ensure funding continues to flow to services, public health teams and the voluntary and community sector. And local suicide prevention plans should obviously be multi-agency and had to be reviewed in light of mental health risks during the COVID-19 outbreak to look at priorities and also what interventions feasible. And then obviously additional priorities or CCGs required to meet the mental health investment standard. And in terms of workforce, continue to deliver mental health workforce expansion as set out in the Health Education England Workforce Plan and supported by ICS STP level plans. So the next slide, if that's okay. So, sorry, I think you just missed one there, Liz. So I suppose in terms of the many initiatives and the development of crisis support and including mental health liaison in that, because I know it's important that mental health liaison has linkage with perinatal mental health. Again, I suppose for discussion, it occurred to me that there's lots of opportunity for connectivity across services, across all age crisis care, particularly around care pathways into admission, urgent assessment and crisis resolution home treatment, where that's an applicable alternative to admission for women who are presenting with acute psychosis. Although I'm mindful that obviously for women presenting with acute psychosis within the postpartum period, admission to hospital is usually the most desired outcome. And in that context, obviously really important that there's good link up with mental health liaison services. So I'm mindful that in some parts of the country where this has been acknowledged as a particular issue or perhaps a particular gap, perinatal services have developed outreach teams into acute and maternity services to support women specifically within this context. But then obviously really important to think about connectivity with CAMS and the development of children and young people services, especially in the context of Future in Mind, you know, back in 2015, that highlighting the importance of maternal and paternal and parental mental health and the impact of poor mental health of parents upon children and young people in terms of their own mental health, but their physical health, development milestones, etc. And then obviously thinking across all of those in terms of access to treatment and waiting times and referral times, for etc. So what I did a little bit is just sort of pull together a few slides regarding how we're trying to move this agenda forward in the South East. So we're working with all of the systems in the South East at the moment to do some detailed baselining and benchmarking to get some narrative regarding what the 24/7 offer is actually like in each system, bearing in mind that in each system and in each locality there may be different modes or methods of operating, and identify areas particularly of good practice both pre and post-COVID, but to think in particular about how those services are joining it with primary care and the primary care networks. But a huge ask, obviously, in particular post-COVID, is thinking about how those services, and obviously particularly mental health liaison, are supporting paediatric and acute adult acute wards and urgent and emergency care departments in terms of the impact of mental health, patients with mental health difficulties within those services, and how mental health services can support and can enrich, and particularly around all age crisis, and particularly at the moment regarding children and young people, especially quite a lot of noise in the system about numbers of children waiting for CAMHS Tier 4 beds and numbers of children and adults waiting for specialised eating disorder services. So next slide, if that's okay, Liz. In addition to the, sorry, that's a repeat slide. I'm sorry, I've repeated myself there. So that's the same slide that I just did. So if we could go on to the next one. If you could do the next slide, Liz, if that's okay. Thank you. So we've been having 3 weekly SIPRET calls to identify problems, blockages, issues in the system, trying to understand the impact of the virus upon acute and community services, impact of ward closures, for example, and again, particularly understanding issues regarding access into specialised commissioning and the interface between secondary care and specialised commissioning. Focus on capacity and capability in particular across all ages, but regarding people with multiple vulnerabilities, and linking in with Health Education England, particularly regarding the workforce requirements, which obviously Liz highlighted earlier, the skill set, the numbers of workforce that particularly required to support emerging patterns and types of need, and to support delivery of evidence base. And then particularly been focusing on out-of-area placements. So large numbers of out-of-area placements at the moment, a particular requirement for psychiatric intensive care, especially for women right now, and thinking about how we might better develop those pathways and extend capacity within region, and also develop improved connectivity with the independent sector when we place patients in the independent sector, either within region or out of region. And we've also established some bi-weekly swabbing, testing and vaccines meetings across the South East with all providers, just to make sure that both mental health patients and carers and staff are having parity of esteem and equity of access to best practice in terms of swabbing, testing and vaccines, and obviously trying to therefore minimise the impact of the virus upon inpatient services particularly, but obviously also people in the community too. So next slide, thank you, is just a table that kind of details some of those priorities really, and we'll just flag that there's been some additional funding over the winter period that's been focused upon supporting mental health crisis care, both in terms of winter pressures, but also from January some discharge planning funding. And we will obviously be working with the systems to evaluate those schemes and look at the outcomes in some detail to understand what works. And also each system has applied for crisis alternatives funding, and we have been evaluating those bids and are just waiting from the outcomes in relation to next steps regarding that from the national team. So next slide. Doing some particular work on mental health 12-hour breaches as well. So where patients are attend the A&E department for mental health reasons, whether that's either a primary or secondary diagnosis, when a decision to admit is made, and when patients don't leave the department then within 12 hours, that's classified as a 12-hour breach. So working with each system again to support our colleagues within the acute trusts and A&E departments to make sure that patient experience is optimised, but obviously patient flow of the department is optimised. So looking at the causes, and at the moment coming up with a number of particular factors as to what may be causing those delays. And then next slide, some particular practice which we highlighted at our UEC group recently regarding children and young people is regarding work that is being undertaken for looked after children in relation to our all-age autism strategy, which I'm sure you're all cited on, but if not, I can provide copies of the draft document. Looking at CYP transformation plans and winter pressures funding, where that's been allocated in particular, and obviously the LTP refreshes due in autumn. Particularly focused work, as I said, on eating disorder services, And then learning from good practice, such as the Sussex business case, which has been presented as an example of good practice for children and young people in terms of the development of crisis services within Sussex. And it's Sam Rogers that's leading on that. And then next slide, and asking all of our systems to think particularly about mental health and inequalities, and particularly within the impact of COVID and in relation to the Advancing Mental Health Equalities Strategy that was published in October 2020. And then next slide. And then obviously looking at, in particular, thinking about the impact of COVID-19 and how that's highlighted the particularly difficult outcomes of people from certain groups, including, for example, the BAME groups. And again, championing that agenda in terms of the swabbing, testing and vaccines meeting that we have every couple of weeks, and asking systems to be working with public health teams and closely understanding the impact of the virus upon their populations and the emerging types of population need. And I think that's it in terms of my slides.
Thank you so much, Sarah.
Thank you. Sorry it was a bit rushed. I do apologise.
Well, no, we were cracking the whip about the amount of time you had.
No, it's fine. I'm so sorry.
I take responsibility for that.
Yeah.
I've actually got a question which I'm hoping that other people on the webinar will relate to. One of the things that's been a constant cause of concern for all of us working in perinatal is that liaison services often wouldn't go to maternity to see women, although that was often the place where they got really quite unwell post-delivery. So has that changed in terms of their commissioning, and is it now sort of included that they can actually attend to maternity? And I guess any midwives or people working in maternity who are on the call today maybe could just put in the chat what their experience of this is, because we've had some really quite worrying near misses out of hours when people haven't been able to be seen in a timely manner on maternity wards.
Well, thanks, Liz, and it's a really good question. It may not have changed within the context of commissioning, if that makes sense. So, you know, my understanding and expectation would be that every mental health liaison service spec includes reach into a maternity unit, if that makes sense. However, some maternity units, unfortunately, may be based in hospitals where there isn't yet a mental health liaison service. Does that make sense? So that I see that that's a difficult challenge, and I think in those instances, as I understand it, certainly where I've come from in the Midlands, our perinatal mental health service was in reaching into the one hospital that didn't have a mental health liaison service. But where mental health liaison services are available, they should be supporting maternity wards and supporting pathways into either acute crisis or admission. So if that's not happening, it would be good to know, and then perhaps in the benchmarking that we're doing, because at the moment, quite handily, we're focusing on mental health liaison in each of our discussions with the systems, along with crisis resolution and treatment. It'd be helpful to know, so we could perhaps pick that up with system leads, if that makes sense.
Yeah. So what can we do from today? Do we want people to get in touch if it's not happening, and then we could pass that information on?
I think that would be really helpful, and any other observations regarding, you know, connectivity with any adult or CAMS or 0 to 25 crisis services, if that makes sense. So wherever colleagues are aware of any issues or bottlenecks or problems, if they wanted to flag, be more than happy to take that forward as part of the benchmarking and
Brilliant. There's some really good stuff going on in the chat that I haven't seen any yet saying that they don't. So that's really good news, and some really great response times as well.
Great, that is good.
And 24/7. So yeah, really, really good.
Great.
I'm so happy to hear that, because I think we've been vulnerable there, to be honest, out of hours.
And as I say, I think some areas have developed services. So I think it's Devon, Liz, that have developed this outreach service for their perinatal mental health team, and that service reaches into the local hospital and sees women in the maternity unit, or the maternity wards rather. But
yeah, I think we've got some examples of that as well in practice, so that's good. I think somebody's got their hand up. Who is this? Nisha, did I see you? Yeah, Nisha.
That's me. Yeah. So I was just wanting to say that one of the things, because we've got great cover when there's on-site cover, but the problem is we don't have funding for 24/7 liaison on the acute site, which is, it's not that they won't come and see somebody on the maternity ward, they will, but they're not funded to. The mental health ward is actually set in Maidstone, and the acute services and maternity are set in Tunbridge Wells. So there's just a cross cover issue, and there's no on-site cover out of hours for that timing. So I think that's a funding issue, and they are in conversation for that. So I think one of the things that we did do in maternity, and I think worthwhile expanding, is having the liaison psychiatrists come and have a little discussion with midwives who work on the labour ward and on the postnatal ward on de-escalation, offering the core team within obstetrics to talk about how de-escalation looks like, what sort of medication we can look at, so that there are a few things that within our power to do to contain for that period that they can't be there, and that period of containment is very important while we're holding, because I think that can be a very anxiety-provoking period, maternity staff, because we're not equipped with the skills, but actually they don't do a huge and in-depth assessment out of hours anyway, but it's just empowering our staffs to de-escalate, to start an antipsychotic or an anti-anxiolytic, to try and to get them into a state that they can be assessed. It's also quite important to start to look at organic causes for an acute event. These are sort of things that feel in maternity. Sometimes we start to get quite helpless when someone becomes agitated. And usually it doesn't come up completely out of the blue. There's usually a prodrome that builds up, isn't it? And being quite proactive when that prodrome builds up as well. So it'd be quite nice if in that part, because obviously funding is a big thing, isn't it? It's great when you've got funding and all the services established, but in that interim, how can maternity staff empower themselves to deal with that circumstance the same way as we would any other medical condition in maternity? Will be quite nice if we, as part of the work that you're doing, is exploring how we can upskill maternity staff dealing with an acute event.
Yeah.
Makes a lot of sense, I think. And I know that and I'm sure, Liz, you will know this better than I, but I know that the Maudsley, South London and Maudsley NHS Trust offers simulation training. And again, in the Midlands where I've come from, we commission quite a lot of the simulation training, and we engaged midwives, GPs, CPNs, perinatal mental health staff in the simulation training. I think it was really successful because it's an opportunity to learn together. So to personalise it to your local care pathways and initiatives, if that makes sense, but then also to learn together as a team, to do that, building, team building, networking, bonding, etc.
Thanks. Are there any other questions from the audience?
That's helpful. Thanks, Liz. Then if there's no questions, I'm afraid I have to dip off to go to another meeting, but I did just want to flag the point about the directory of services and the crisis lines. So just to make sure that colleagues within perinatal mental health services are aware of crisis line numbers, are aware of crisis alternatives, and where the services within the voluntary and community sector, perhaps particularly, that support women in this vulnerable time, just to make sure that that is reflected in the DOS and the service finder, for example. Does that make sense? And again, happy to have a discussion with you offline about that, if that makes sense, just in terms of how we might want to take that forward, if that's okay.
Yeah, of course.
Yeah. I'm going to meet the DOS leads quite soon, obviously still being quite new in post. I'm going to meet the DOS leads quite soon, so happy to pick up a discussion with them just to make sure that perinatal mental health isn't excluded.
Brilliant. That's what we like to hear. Thank you so much, Sarah.
No worries. Thank you. Take care, everybody. Bye-bye.
Thank you.
Bye.
Okay, so lots of food for thought there and lots of new stuff and looking like lots of gaps finally being filled. So I'm delighted to hear all of that. So I'm just going to introduce something which is we're going to feature this in future webinars, but it's looking at those slightly different roles, as Liz said, within the whole perinatal pathway across all of our stakeholders. And I know there's a couple of you on the call today that I will be coming after to do a slot like this in future webinars. So Becky and Jules coming to mind, so watch out you two. I'll be after you two to talk about your roles. But today, because we've been talking about crisis, we've actually asked Rachel, who's one of the rapid response nurses, to talk about her role within the perinatal mental health specialist team. And she couldn't be with us today because she's on leave, so we've actually got her to do a little film for us, which always makes me slightly nervous because we've had shockers with films in the past, as those of you that have been with us from the beginning will remember. So yeah, I'll let Rachel speak for herself, I think, if we're ready to go, and I can pick up some questions afterwards if there are any questions following this. I know some of you guys will have this role, but I thought it was quite interesting to share it. Okay, thanks.
Hello, my name is Rachel. I am a perinatal mental health nurse and I work for the perinatal community team, which covers Hampshire and the Isle of Wight. We are a specialist service for women who may well be experiencing severe mental health problems, either in pregnancy or the postnatal period, up until their baby turns 1. I have a rather unique role within the team and I am called a rapid response nurse. And there are 2 of us in the team, and we first introduced this role around 2 years ago. So our role is very different to a typical patch nurse or community mental health nurse in that we are not patch dependent. So together we cover the entire county, so we cover a very large geographical area, but we do still work very closely with our patch nurses, and the main goal of our role is to offer more of a rapid response to either new referrals or women who are already existing on our caseload. So ordinarily, we carry a much smaller caseload in comparison to the patch nurses, which then allows us to have a bit more flexibility with our diary, and more flexibility to then see those women who may well be extremely unwell and needing that timely response. So all referrals come through to our service and go through to the team leaders, and a proportion of those women will then come across to us for a telephone assessment. As part of our rapid response role, we then aim to make contact with that woman over the phone within 2 working days, which is very different to how the rest of our team work. During that telephone call, we will then almost do like a second triage and do a very brief telephone assessment with that woman, to really see what's going on for her, to hear her point of view, to assess level of risk, level of severity, and that perinatal need. And from those telephone assessments, a proportion of those women will then be taken to have face-to-face contact, and we ordinarily will do that within the first week of that telephone assessment appointment. And those women that we do then take to face are likely to then need some short-term intervention from the rapid response nurses. So again, that's a very slight difference. So our patch nurses often work with women very long term, whereas the rapid response nurses will provide short-term intervention, often around 5 to 6 sessions, depending on what the woman will need. So a proportion of those telephone assessments may well not need face-to-face contact, and actually a lot of the time what we find is GPs have already been incredibly proactive and helpful and maybe have initiated medication. So for some of those women we will hold over the phone whilst they are titrating onto medication so that we can review the response that they've had to that medication. And then a lot of the time, once that medication's kicked in, they're feeling a lot better, and we will either discharge them back to primary care or signpost them to other services. For some women, it may well be that there's no perinatal specific need identified, so we will then refer them on to the CMHT, or it may well be that actually the severity isn't there, and so we will then refer them on to IAP services and talking therapies. So for the women that we do take face-to-face, so our role is that we offer short-term support, and a lot of the time that is enough for women. So it may well be that they've been referred through to us in crisis, or it may well be a new onset condition. A lot of the time we tend to see women with very high anxiety, particularly in those early days, after they've had their baby, almost that adaptation to motherhood, that high anxiety, high stress, which does tend to settle very quickly, and then mum is feeling a lot better within herself. So it may well be that as that risk comes down, as that severity comes down, after a couple of sessions of a combination of, talking therapy type style work alongside medication where appropriate, we then may well discharge that lady. Or it may well be that actually in getting to know that woman, actually she does need longer term support. And so what we will do is that woman will go in for allocation to her local patch nurse, and we will then arrange a joint appointment to hand that woman over to the patch nurse. So essentially what that does is allows that woman to start having that treatment and that support rather than waiting possibly a number of weeks before meeting that patch nurse. And I guess a really positive thing in working that way is it often prevents that woman getting worse and going into crisis. And it also means that she gets that timely response. She feels heard. She can, begin with that treatment, which is essentially what we want to be doing for those women. Another part of our role is that there may well be some women who aren't appropriate to have that telephone assessment, and it may well be that actually we forego that part of our role and we just go straight to a face-to-face assessment. And there are particular women who we might want to be doing that for, particularly if there are quite a lot of perinatal red flags. So we know that the perinatal period is a very vulnerable time for a lot of women, particularly women who may have a diagnosis of bipolar or a previous history of psychotic episodes. And for those women in particular, we will go straight to face-to-face. If we can, we will aim to try and get out to see them within the same day. However, if there is a safety plan already around that woman, so for example, she's already in hospital or she's got the crisis team involved, the very latest is we will then see them the next day, but we will always ensure that we've spoken to the teams involved to ensure that they're aware of how to access a mother and baby unit if they need to escalate that before we've gotten out to see them. Another wonderful part of our role is that we work very, very closely with our mother and baby unit. So, for example, women may well sometimes be admitted for a hospital admission who aren't on our caseload. So we will immediately be allocated as that lead practitioner. We will go and introduce ourselves to that woman and almost act as that kind of transition and that making sure that it's smooth transition back home once they're discharged from hospital. So we will be a part of any CPA meetings. We will provide the 48-hour and the 7-day follow-up for that woman. And then once she's home, we will devise together a care plan around what kind of support she needs and really determining whether it's that short-term intervention that can sit with us or whether it's that patch nurse who then needs to take over slightly later. We also act as proxy care coordinator for women who are already on our caseload as well. So, for example, when our patch nurses go on annual leave or may well not be available, we then step in, particularly if that woman's on the ward, again, to do those CPAs or those 48-hour follow-ups. Or maybe if that woman has significantly dipped and is needing more enhanced support than, say, the patch nurse has available to offer, we will then step in and offer a little bit more support. We tend to also work very closely with our crisis teams because we're not a crisis service and we cannot provide an urgent response to women. So, for example, if women are needing more face-to-face contact than once a week, we will work closely with our crisis teams to try and facilitate that. And often that works out really, really well for those women. So that's been a snapshot of my role. I hope that's been helpful, and thank you for listening.
So there we go. That's our rapid response nurse. Has anybody got any questions that hopefully I might be able to answer about that role? I know that a number of you on the call within specialist perinatal services will have something like this or something very similar to this. I think we're not in a world anymore where our sort of generic nurses within the service can pick this stuff up, because services are so busy now, and caseloading CPNs just do not have the capacity for those urgent and emergency assessments during office hours. So I know it's been an incredibly valuable role within that service. Just wondering if anybody else has got experience of it that they want to share, or if not, we can go straight on to our next speaker. No, it's all gone quiet. So in that case, I will introduce our next speaker. Oh, hang on, we have somebody here. Yeah, so we've got from Becky in Berkshire saying that the rapid response nurse is really easing pressures and it's a great role. So for those of you that haven't developed this role yet, it's certainly one to think about. And remember, you do have other people around that have already done it that you can call on if you're thinking of going down that route. Thanks for that, Becky. Excuse me. So I'm going to introduce our last speaker. So we've got Detective Inspector Amy Schock, who is going to talk to us about child abuse investigation. So another aspect of that crisis work, so important, that we always have our safeguarding head on when we're working with our complex women. So thank you very much, Amy, and I'm going to hand over to you.
Thank you very much, and thank you for inviting me to sort of chat to you all for about sort of 15-20 minutes. And again, just sort of reiterating what sort of other people have said, really, it's really sort of humbling to hear how hard everyone is working, and it's been difficult for lots of us in lots of different ways, and it's kind of reassuring in some way to know that we are all in it together, and the hard work that's going on is really nice to see. So hopefully over the next 15 minutes I can just give you a bit of a snapshot of child abuse investigations. So my name's Amy Schock. I'm a detective inspector from Hampshire Constabulary. So I'm based at Basingstoke, and I oversee a team of police officers and investigators that deal with all manner of sort of child abuse, and work with very closely with other agencies to support families in what has been sort of a challenging year. So next slide, please. So what I intend to cover is really just to kind of reaffirm or reiterate that whilst I'm from Hampshire, actually what I talk about is national guidance. So whilst every area might have local differences and organisational things that differ from area to area, what we do from an investigation and multi-agency view is very much national and based on national guidance. So hopefully this will apply across the board. So first off, really, it's probably useful to define what is child abuse, because I think it gives you a bit of an indication that it can pretty much be anything. So it can relate to an intentional act, or it can be a lack of love, care and attention. It can be physical, emotional or sexual. It can be online and it can be in person. And importantly, it can be over a sustained or long period of time, but it can be a one-off action. So it's just kind of, from our point of view, we deal with all of that and everything that comes underneath it, really. I'm going to talk a bit about the COVID effect, because that's all anybody can really talk about at the moment. But in relation to talking about the crisis element, then very much with regards to child abuse, the changing picture over the last year has been significant and concerning for a number of reasons. And the challenges really faced by not just us, but you know, yourselves and all agencies involved in the safeguarding of children, I think really reinforces that need for this multi-agency response and that continued effort to communicate with each other about how we can respond to this in the best way possible. I'm going to touch on a bit of advice for professionals like yourselves who are engaging with children and families. It's clear from the previous inputs that you're dealing with a number of vulnerable women and families in probably what is a very intense period of time for them. So hopefully just giving you a couple of indicators of what might be neglect or abuse and how you can potentially respond to any disclosures or concerns you have. And then the referral process itself. So if you were to make a referral to the police or any other agency about a concern for a child, just to give you a snapshot of what we would do with that information and what kind of the possible outcomes are, so you can kind of see from beginning to end what that might look like for the family and the well-being of the child. And then at the end, there's a couple of useful websites and resources which I will touch on during sort of the next 10 minutes, but if you want to read more in relation to getting a bit more information or context to what I talk about, then there's some really good links that you can have a look through. So next slide, please. So the impact of COVID, so the last year or so in relation to how that has impacted child abuse investigations and referrals has been significant in a number of areas, really. I think probably it would be obvious to say that there are increased concerns for children and those most vulnerable children during this time regarding what they're subjected to, either through physical or sexual abuse, as well as what they might be exposed to with living conditions and the environment within the family setup, and what they're denied, so education, emotional support, kind of social interaction with others. So the increase in stresses to parents and caregivers, be that financial or relationship breakdowns, as well as isolation from support networks, so that might be friendship groups or peers, and a reduction in overall protective services, so less professionals or services being engaged face-to-face with children, means that we are seeing an increase in children being exposed to an environment that is leading to physical and sexual abuse and cruelty and neglect. So a couple of statistics which have been produced by the NSPCC. This is after sort of the first wave of COVID and lockdown, but we're likely to get a similar picture given to us sort of in the coming months, is that calls from children, specifically females, about being sexually abused by a family member that they were living with went up from 8 to 23 a week, which obviously is tripled, so that is a real concern. Calls around domestic violence concerns, so this is from adults who are concerned about children being exposed to violence within the home, went up by 50%. And calls to the support line from children who were disclosing physical abuse and being physically abused by people within the address went up by 22%. So across the board, we are seeing children reaching out to talk to whoever they can really about what's happening to them. So the concerning bit of that really is that referrals to us have decreased, largely around the closure of schools, because we do get a lot of referrals from teachers or adults who have that day-to-day interaction and pick up those changes within the children. So these children have less opportunity to speak to a trusted adult, really, that kind of safe place that they can go and talk about what's happening. And that normal support mechanism, be that through after school groups or just general friendship groups that they might speak to, means that there are fewer chances for us, along with sort of the partners we work with, to identify abuse, intervene and support families and safeguard children. So when lockdown ends this time, as it did the last time, we are expecting to see a significant increase in referrals, and probably more concerning is the severity of the abuse is likely to be far more serious, because there has been a lack of opportunity to intervene and sort of get in there early to sort of support these families. Next slide, please. So signs that something might be wrong. So hopefully that sort of previous slide gave you a bit of an indication of how important it is for any agency, professional, individual that might be interacting with children at the moment, for whatever reason, how important it might be that your interaction is. It obviously is anyway, but in terms of it being an opportunity for a child to disclose or signs to be spotted, I think that's the kind of message that hopefully we want to get across, is that any interaction with a family, there is an opportunity to kind of intervene or refer to make sure that we can intervene. So kind of perhaps the more significant signs or things that you might see that immediately jump out at you as being indicators of a child that needs some support or a family that needs some support. We might be looking at condition of the house, so unhygienic conditions, things like heating not being on, children being cold, bed sheets being not cleaned, animal feces around the address. They are sort of indicators of neglect and the priority of the caregivers or parents not being on the well-being of that child. Along with that, you've got the kind of hygiene of the child, so poor dental hygiene, not going to the dentist. Perhaps they're wearing nappies and they're at an age where you'd expect them to be toilet trained, or they're bedwetting, and again you'd expect them not to be. Again, with just general sort of cleanliness and sort of showering and all of those bits and pieces. Access to food, and we're talking sort of a healthy, nutritious access to food, and the ability to be able to kind of, we know a lot of families are going through a really difficult time financially, so any sort of indications that there isn't enough food at the address for the family gives us an opportunity to look at how we can sort of support them. And access that children have to toys and age appropriate toys is another sort of thing we look for whenever we're doing home visits around, how supported is that child in its kind of development in sort of across the board, as well as sort of physical and emotional. So other things that might jump out as being indicators of neglect or potential abuse, or something's not quite right, is that child's attachment to their parent. Do they have a strong attachment? Is there sort of clear indicators that they don't engage with the parent? There's a lack of sort of affection between them. And again, their engagement with their sibling, if there's any signs of aggression or violence or bullying, that can sometimes indicate a bit of a power struggle, and that there are sort of underlying tensions at the address. And for those of you that perhaps know these families quite well, and you've spent quite a lot of time with them, you might see a behavioural change, and it might be one way or the other. You might see a child who's quite extrovert suddenly become quieter, or a child that's normally quite quiet perhaps start to behave in a more aggressive or vocal way. So often that can be a sign that something's going on and that child lacks the sort of communication skills or sort of emotional awareness of being able to articulate what it is that's bothering them. So signs for us in relation to potential sexual abuse is if a child is using quite sexualized language or adult language. They're talking about genitalia, or they're having inappropriate conversations, perhaps with siblings or in your presence, if you hear something like that, then that can often be a sign that that child is being exposed to something within the address that may or may not be an indication of sexual abuse, but certainly some potential inappropriate behaviour. But less obvious things, I suppose. So they might be things that you see visually or are quite sort of apparent to you when dealing with these families. And again, I'd sort of stress they're not all clear signs that there is abuse or issues at the address, but it should be enough to raise a flag, and kind of certainly would be enough for us to look at that family and what might be going on. But less obvious things, so domestic violence, verbal or violent, can have a really significant impact on that child. So you might have a family who care for their child, it's a nice address, they've got food in the fridge, they've got lots of nice things to play with, and on the face of it, it looks quite a healthy environment. If there is violent and verbal abuse going on between the parents, then that can have quite a significant effect. And just to give you a bit of an example of that, would be around sort of children who we had a domestic violence case where sadly the father murdered the mother, and prior to that we weren't really aware of anything being too bad within the address, a bit of verbal domestic but nothing more. The children were believed to have significant learning difficulties, developmental delays, potential autism, but when we removed those children from that environment and they were placed into foster care and then further on adopted, all of those things that were attributed to the development of the child essentially disappeared. It was a reaction to what was going on within the address. It was an emotional and physical response to witnessing trauma. And so it was just sort of an indication really of exactly just how much damage can be done from words alone, I think, on that occasion. And again, I think just professional curiosity. So you guys are obviously clearly very experienced in the work that you do, and know these families and know these children and individuals far better than we ever will. So if there's something that's not right, then we would encourage you to sort of pay attention to that. Next slide, please. So what to do if you've got concerns for a child. So if danger is immediate, if you're at an address and there is clear and immediate danger, then remove yourself and call 999. We can respond and utilise powers to sort of remove that child into police protection. If you've got concerns where you don't think the child is immediately at risk, but there's just something not quite right, so perhaps some of those indicators that I was talking about before, you can call 101 and report it once you have left. So you might leave the address and be on your way back or in the car, and you can report it that way. You will have your own referral mechanisms, I'm sure, so just familiarise yourself with those, and make sure you're aware that if you've got any concerns, you know how to put that across. And if a child tells you something, so if you're there and perhaps the child suddenly discloses something that you feel is an indication that someone else needs to get involved, then we would just encourage you to listen. So you may need to ask a question or two to clarify their comments, but don't actively sort of ask or follow up questions, because when we become involved, we will deploy officers that are specially trained to take that child through the disclosure. So it's a really difficult position to be in, but just if in doubt, you might need to ask one or two questions, but you can remove yourself and pass that on to sort of the police, who'll be able to sort of take it from there. Next slide, please. So what happens when you make a referral to the police? So again, just reiterate, this is national guidance and it's based on Working Together to Safeguard Children 2018, and it's designed to work with partners to safeguard and promote the welfare of children. And the main thing about this is really the objective about keeping families together. That is always the primary aim. So a referral will go in, it would go to something called the Multi-Agency Safeguarding Hub. So that is staffed by police, it will have health involved, it would have child services. So anyone who has had any engagement or has any knowledge about that family would have a strategy meeting to look at the risk, response and support that's required. More often than not, that leads to what we call a Section 47 visit, which is where police and child services go out. The police officers are trained to speak to children at an appropriate level and engage with the child. And depending on what comes out of that, both the visual examination of the address and any conversation with the child, then we make a decision around any criminal investigation that's required. Can we remove Can we remove children there and then into police protection? Yes, we can. We have a power to do that for 72 hours, but that's only if significant harm is likely to be caused. So we do use that power. It's an important kind of tool for us to really safeguard that child, but it is a high level to reach, and we always try every other option first to try and find a family member or someone else that can assist with looking after that child. If we make arrests of parents or caregivers, we would look to place the child with a family member. If that's not possible, then we look at foster care. And again, if we are looking at really serious cases of criminal offences and we're looking at permanently removing those children, then we work very closely with child services to go through the family court and look at interim care orders. So there is quite a lengthy process involved, but I suppose the main thing is we can remove a child there and then if we have real concerns, but we will always look to work with the family and social worker to try and find something that we can put in place in the interim. So in terms of our outcomes, obviously we have the opportunity to investigate and charge for criminal offences, but we do use a lot of out-of-court disposals, and what these are conditions where we work really closely with children's services to support parenting and to protect the child. So they can range from anything from a parenting course. We show them videos which look at acute childhood experiences to parents to make them aware of what their behaviour can do, and I put a link to that at the end of this that hopefully you'll be able to watch. But the main thing is that we really do try and work with the family to find out what's going on and what we can do to support them. So yes, we are, we do charge people and we do pursue criminal investigations because clearly there's often a need for that. But we do look at all the other ways in which we can support that family and that child, because the main thing is we want to keep that child with their parent or caregiver. And the voice of the child is always central. What is best for them? We've come a long way, I think, in the last sort of 10 years within the police of really prioritising what that child is saying to us and what they need, as opposed to making decisions for them or other agencies making decisions for them. So if in doubt, just flag a concern. It really could be an opportunity for us to support families before things escalate. I think it's really important that we use every opportunity, especially at the moment, just to highlight things that might just indicate the start of a family in crisis, so we can get in and kind of support them at the earliest opportunity. So next slide, which is the final one. So there's a few links there. The first one is a link to the NSPCC reports on abuse. So those figures that I gave you right at the start, if you click on that link, that will take you to individual reports on domestic violence, sexual abuse and physical abuse. And yeah, they're really interesting to read, and they're written in a really sort of concise way, so not too difficult to sort of wade through. The second link, so this is on the Hampshire website, council website, but it's a neglect indicator chart. So it's a really good, quick, easy guide as to what might be an indicator of neglect. So if you felt like having a look at that, just to reiterate what I said at the start, that would be really useful. The third link is a 7 to 8 minute YouTube video called Behind the Badge, and it's filmed at Hampshire Constabulary, and it walks you through what happens when a referral is made, how child abuse investigation teams will go out and speak to the child, what the outcomes are, and how we work with other agencies. So it just gives you a bit of a snapshot of that referral process that I spoke about. And then the last link, again, is the acute childhood experiences video. So this is one of the conditions that we may deploy to show a parent if we think their parenting or their behaviour towards their child is causing us some concern. And it's actually quite an impactful 7-minute watch, so it's kind of animated as opposed to having real people in it, but we're getting really good feedback from parents who are watching that and recognising that behaviour they didn't necessarily see as damaging their child's sort of emotional well-being is having much more of an impact. So hopefully they will be useful. And 20 minutes, so just about. Hopefully it wasn't too quick, but thank you so much for having me. It's been really good.
Amazing timing, Amy. Thank you so much. And what a great talk for us. I'm still reeling from your first slide when you talked about the increase in various different types of abuse during lockdown, and just thinking, oh, thank goodness these kids are going back to school as one place where they might get, you know, be able to build up a bit of resilience and have other people to talk to. So yeah, it's just so important. And all of these resources, I think we can all utilize these with like new starters to our teams, induction for our students. So I think they'll be well used. So thank you so much.
Thank you.
Yeah, well, I think we could take a couple of questions if anybody's got any pressing ones. Okay. Doesn't sound like it. So thank you once again, Amy. That was amazing. And I'm going to hand back to Liz now, who's just going to finish off for us.
Oh, just get my video back on. Thank you very much. I hope you've all enjoyed this morning. Certainly lots of feed for thought and some really good presentations as always. So just to remind you that the next webinar is now on the 31st of March, and invites with that updated date have been sent. And the focus will be on the long-term plan, and particularly on dads and partners will be our theme. And then the future webinar dates for the rest of the year are there. And if you're not on the distribution list, then please let us know and we will get you added. Can I have the next slide, please? And then just to remind you, as always, that the slides will be shared after the webinar, as well as the recording of the webinar, and the link to the previous webinars on our website are detailed there. And nothing more for me to say, but have a good rest of day, a good rest of month, and we look forward to seeing everybody in March. Take care, everybody.